Welcome, everyone. I'm Candace DeMatteis, Policy Director for the Partnership to Fight Chronic Disease. Thank you for joining us today for the fourth segment of At What Cost, a series of discussions with leading experts sharing new research and their perspectives relating to what we know now and what we can anticipate as implementation of the Inflation Reduction Act, particularly for Medicare drug coverage, continues to unfold. This series examines the early evidence related to the IRA's impact on Medicare drug coverage, medicine access, and also innovation. This discussion comes after the announcement of Medicare's first list of 10 negotiated drug prices and after some details about what Medicare drug coverage in 2025 will look like. We now have a better understanding of the near-term impacts of the IRA on Medicare drug coverage and its potential ripple effects. The IRA's drug pricing represents much more than a list when considering impacts on coverage, access, and costs. And today's discussion among policy and economic experts will focus on what's next with access to medicines, Medicare drug coverage, and the realities of cost savings at the pharmacy counter. We have a lot of ground to cover, so let's dive right in with our panelists. Joining us today are Dr. Mark Fendrick. He's a professor of internal medicine at the School of Medicine and a professor of health management and policy in the School of Public Health at the University of Michigan. Both a physician and an economist, Mark conceptualized and coined the term value-based insurance design, or VBID, and currently directs the VBID Center at the University of Michigan, the leading advocate for development, implementation, and evaluation of innovative health benefit plans. Mark is also elected member of the National Academy of Medicine, serves on the Medicare Coverage Advisory Committee, and is regularly invited to present testimony before several different congressional committees. Ken Thorpe is chair of the Partnership to Fight Chronic Disease and a Robert W. Woodruff Professor and chair of the Department of Health Policy and Management in the Rollins School of Public Health of Emory University. He also co-directs the Emory Center on Health Outcomes and Quality. Throughout his career, Ken has worked in and helped shape the health policy programs at several universities across the country. He also was Deputy Assistant Secretary for Health Policy in the U.S. Department of Health and Human Services from 1993 to 1995 during the Clinton administration. He is a sought-after expert on health policy and economics with policymakers at the state, national, and international levels. Ipsita Smolinski is a veteran advisor on healthcare regulatory and legislative issues with more than 20 years experience in healthcare policy and economic analysis. As the managing director of Capitol Street, she advises clients on key trends and major actions coming out of Washington, D.C., as well as at the state, court, and stakeholder levels. These include healthcare legislation moving on Capitol Hill, and actions from CMS, FDA, NIH, FTC, and a host of other agencies, as well as emerging and commercial market trends. Her primary focus is forecasting the impacts of health policy through data-driven economic analysis. Last but certainly not least is Joel White. He is the president of the Council for Affordable Health Coverage. Joel spent 12 years on Capitol Hill as professional staff, where he helped enact 9 laws, including the 2003 law that established the Medicare prescription drug benefit and health savings accounts. He also worked on the 2006 Tax Reform and Healthcare Act, which reformed Medicare payment policies. He served 6 years as staff on the Committee on Ways and Means, and prior to his work on the Committee on Ways and Means, Joel worked for Congressman Jim Greenwood of Pennsylvania for 2 years and Congressman Chris Shea of Connecticut for 4 years. He's also the co-author of the book, Facts and Figures on Government Finance, which brings together data on public finance at all levels of government and compares taxing and spending levels spanning half a century. So a fantastic panel. We thank you all so very much for joining us. I'm going to dive right in with some questions, and we've got some pre-audience questions, so we're going to include those here as well. Joel, if you don't mind, I'm going to start with you. The Council for Affordable Health Coverage recently released some research on the impact of the reforms under the IRA to Part D drug coverage. and highlighted some key areas where there are some concerns. First, what are those major changes to Part D coverage in the IRA, and how are they affecting coverage and costs for beneficiaries going forward?
Yeah, thank you, first of all, for having me here today and for your kind introduction. I think a lot of people have focused on the Medicare drug pricing provisions of this law, but the law also made major changes to the Part D benefit design, primarily reducing beneficiary out-of-pocket costs. For example, in 2025, there'll be a $2,000 out-of-pocket cap on expenses for beneficiaries. Previously, beneficiaries had to pay 5% of the costs above $3,300. And so that's a significant benefit for about 1.5 million Americans who rely on high cost medicines above that $2,000 threshold. The second thing is it allows beneficiaries to smooth their costs over the year. So if they're facing high drug costs, for example, in January with a deductible on their health plan, they'll be able to smooth that cost out over the entire year and pay a portion of it each month rather than upfront all at once. Finally, the law also significantly increased extra help available to low-income beneficiaries by making everyone under 150% of the federal poverty level eligible for full subsidies. A couple of other provisions that even came up in the debate last night, capping insulin out of pocket at $35 per month, and then providing many vaccines free of charge out of pocket to beneficiaries. So the impact of those changes are significant for people, particularly with high costs above $2,000. But what the IRA also did was it readjusted the risk that different people pay in the benefit and put a lot of that risk on health plans. Health plans provide the benefit in the market voluntarily, and they make decisions about how to set a premium based on the coverage required by the law. And oftentimes they mix up the benefits and make more generous benefits available to seniors, like $0 copays or reduced cost sharing, expanded coverage in the coverage gap, et cetera. So what we're seeing in 2024 is that plans took on about 5% more risk on higher costs. And as a result of that, and a few other changes, increased their monthly premiums on average by 21%. Next year, as we get a more generous benefit, we're expecting plans to double their premiums. So we're estimating about 100% increase in premiums. We've already seen plan bids come through at 180% higher. That's unheard of in Medicare Part D. The 2024 increase was the largest premium increase ever. The second impact is that we're going to see fewer plans. So about a 25% reduction in the number of plans that were available in 2024. We know big plans are jumping out of the market for 2025. So seniors are going to have to shop around for a different plan and get change up their coverage. The third effect is there's the fewest number of low-income subsidy benchmark plans. What that means is for that extra help, for that senior is at 150% or less of poverty, they're gonna have to shop around for a plan that's gives them the full premium out-of-pocket coverage extra help in order to receive that help. And there's only 3 available average nationwide to those beneficiaries. The fourth impact, we're seeing plans manage this risk in different ways, but in general, most plans, 83%, are narrowing their formularies, which means they're covering fewer drugs, and they're reducing the number of drugs available at each level of cost sharing on the plan. 73% of plans are doing that. So it's really less access to products, and those products are being managed much more tightly. So a lot more prior authorizations or requesting, saying, "Mother, may I get this coverage before you give me the coverage?" A lot more step therapy or fail first, which is you've got to try the lowest cost product before you start moving up to the product that may work for you. And a lot more use of aggressive appeal denials. So like if a drug isn't covered on the formulary, beneficiary needs it, they appeal to the plan to get it covered. The plan is being much more aggressive about denying that coverage. So the combination of all those things in the market is leading to a very disruptive market And the report that we released earlier this year, available on our website, kind of highlights some of those dynamics. And one of the things is that CMS saw those same trends. And so they announced a demonstration program in early August to essentially buy down the premiums so that seniors and the disabled wouldn't be faced with such high premiums. It remains to be seen how many plans took that money on the table and how much premiums will be affected. We will see the impact on October 1st when seniors and the disabled start shopping for plans in advance of open enrollment, which starts on October 15th. So a lot more disruption in the market, a lot higher premiums, a more expensive market, fewer choices, and for people with chronic illnesses, maybe a tougher time getting the products that they need.
Thanks, Joel. There was a lot to cover there and a lot of changes, as you mentioned, within the IRA. And I want to talk to our other panelists about some of that as well. Mark, a lot of your work, as I mentioned in your bio, focuses on value-based insurance design and making more accessible, high value services like vaccination, for example. I was curious what you think, given what Joel was talking about, the anticipation of higher barriers to access, how that fits within, your work. And are there some lessons that could be taken away from value-based insurance design to really kind of help to address some of those challenges? Because after all, Medicare is a healthcare program.
Candace, thanks so much for having me. And it's just such a pleasure to share this virtual podium with these amazing, esteemed experts. It's always a pleasure to follow Joel because he sets me up perfectly. And you can only imagine, as a practicing general internist, how challenging putting all these things together are for our seniors and other vulnerable Americans who are trying to figure out their way to get the best care possible. So first, for those who'd never heard of value-based insurance design, even though certainly Ken is old enough to know what it is to sound like a broken record, since early this century, my colleague Michael Chernow, now at Harvard Medical School and chair of MedPAC, and I have been trying to convince public and private payers that as Americans have been asked to pay more for all clinical services, right, to instead of set cost sharing on the price of the service, where a low cost service, depending how valuable it is, costs my patients little, and high cost services, even those that are the most valuable to their individual and population health, are asked to pay more and more and more. And it was in the early 2000s where Mike and I came up with this idea of clinically driven or value-based insurance design, that instead of setting cost sharing on price, we instead set cost sharing on clinical value, such that instead of cheap things being cheap, the things I beg my patients to do cost little or nothing. And for the things that people may want or may seem attractive to do where the evidence does not show clinical benefit and sometimes actually causes harm, those are the services that we should have high cost sharing on. And many of the levers that we'll talk about later that Joel already mentioned that are happening for high value services. So many people don't know, who see me casually, the reason why if you got a COVID test or a COVID shot or a COVID treatment at no cost, it was because of a federal implementation of value-based insurance design by the previous administration. And before that, the preventive services provision of the Affordable Care Act, which now offers a mandate of zero cost sharing for almost 100 high-value evidence-based preventive services. I believe, Candace, you, my panelists, and just about everyone we know have benefited from zero cost sharing for one of those preventive services. But I'm always thrilled to follow Joel, and he's one of the very few that when we talk about what's going on specifically with the Inflation Reduction Act, is while all the media attention has come on the drug price negotiation piece, which is 10 drugs not coming into place till over a year from now, I just want to reiterate quickly where more people need to pay attention of the health aspects of the IRA, many of which I worked on with people like Dr. Thorpe and others. My tagline for years is my patient should not have to have a bake sale to afford her insulin. And it's just really thrilling to know that the previous administration was the first to think about an insulin copay cap through a model program through Medicare, and now it's national through the Inflation Reduction Act. We worked for decades to remove cost sharing for Part D vaccines that Joel mentioned, just for the non-clinical people out there, that's predominantly the shingle shot. And we've already published in JAMA showing that comparing post-IRA to pre-IRA, shingle shot uptake in Medicare patients is up 46%. So people are in fact responding to cost sharing in this regard. But I do want to spend also, Joel, amazing to talk about where the action is, which is this $2,000 out-of-pocket max. I mean, you all have heard of someone who has paid unbelievable amounts of money for drugs they don't want to take that are often life-changing or life-threatening. And the idea that we've already seen some out-of-pocket cost reductions in 2024, and January 1st will be a very big year for Medicare beneficiaries, particularly those who pay a lot out of pocket for specialty drugs and other drugs that are often really expensive, but really, really high clinical value. So the idea that most people don't know about the out-of-pocket max, and I'm just going to swing quickly to this smoothing element, or something known as the Medicare Prescription Payment Plan. I'm not sure I like the name, but this is the point that Joel mentioned that actually allows patients to not pay $2,000 out of pocket in January if they have to take a specialty drug that's often life stabilizing and sometimes loss saving. The Federal Reserve has said that 40% of Americans don't have $500 in the bank, which is why we have argued against the idea of blunt instruments like deductibles or these high out-of-pocket costs that are independent of clinical value. The point about MPPP or smoothing, and I hope everyone listening, especially those who have big networks in the media, is that the smoothing program is opt-in, as opposed to what the few people who've heard about it think it comes about naturally. Open enrollment, Candace, is a month away. And my casual surveys of folks who are in the know in healthcare have never heard of MPP and are not alerting the patients that they are certain would benefit from not having to pay $2,000 on January 2nd about the program. For reasons that Joel will explain more articulately than I. There's lots of reasons. Plans are overwhelmed, and there are financial attributes to the MPPP that even add to these increased services that are being asked for through the IRA. So I don't see, I've not seen a single patient who's told, you're likely to benefit from smoothing. And in fact, I strongly suggest when you get your mailing on October 15th that you check that box before you do anything else. I've told clinicians in rheumatology and oncology and other areas where specialty drugs are more prevalent to keep their eyes out, because the patients who are going to benefit most are those who are often challenged with issues of literacy, multiple chronic diseases, lack of internet access, and things like that. So I want to close, and hopefully we'll talk about some of the drug price negotiation aspects later. But when it comes to many of you who care about money, and as I like to say, Candace, I did not go to medical school to learn how to save people money, but I understand that to have a position in this great deliberation, you have to care about money. That the Biden administration estimated that the out-of-pocket savings from the first 10 negotiated drugs is estimated to be about $1.5 billion. I actually think it'll be substantially lower than that. The same administration has estimated that the three non-drug price elements that Joel mentioned, insulin copay cap, Part D vaccines, and most importantly, the $2,000 out-of-pocket max, will save $7 billion, more than 4 times the estimate in out-of-pocket costs for Medicare beneficiaries, impacting not those few single million patients who take those negotiated drugs, but it's estimated that over 1 in 3 Medicare beneficiaries will see a reduction in their out-of-pocket costs because of the IRA. So I'll close with, what I've heard this many times, Ken, Americans don't care about healthcare costs like the panelists do. They care about what it costs them. So while the out-of-pocket cost issues are extremely important and have been the crux of my work, you can understand that if you buy more high-value drugs, the likelihood of premiums going up is something that's real. And that's why, as I turn it back to the panelists, that's way above my pay grade, and how you deal with that trade-off. of spending more on the drugs that I really want my patients to have access to, we have to pay for it somehow. While I'd rather not raise premiums or deductibles, I'd much rather to see the American healthcare system have the courage to finally stop paying for those services that we spend billions on that at best provide no clinical benefit and in some situations actually cause harm.
Yeah, no, thank you so much. It's a challenge to be sure. Ipsita, Joel mentioned a lot about changes in the insurance market with the additional health plans taking on additional risks. We also know that's going to continue to escalate with the 2025 plans, and we're waiting for October 1 to see. But I was curious what you're seeing in the marketplace when it comes to health insurance, but then also what you're seeing on the investor side in terms of drugs. The first list is 10, the next is 15, but it escalates. And then policymakers are talking about really making that much faster, expanding the list to 50 or 100 drugs, going to the private market. I'm curious what you're seeing in the market in response to the IRA as it is now, and then what we might anticipate down the road.
Okay, great. Thank you so much for having me. Really love your events and I appreciate the time. I guess, yeah, so I'll talk a little bit about insurance first and then happy to pivot over to the drug side. I just want to echo what Joel said, which is that, premiums already went up for Part D plans. They're just going to again. We've got this demo that, is kind of interesting and I think is raising a lot of questions. 2025 is right around the corner, but I think there's really no question that premiums will spike again. And there's already consternation, I guess, concern in the plan community around Medicare Advantage and Part D, but MA, for instance, is the public-private partnership between health plans and Medicare, of course. We have 2 years in a row consecutively of rate cuts to plans, which is concerning to the plan community. And then you also have a brand new risk adjustment program called V28, which plans are also adapting to. Some would say that these changes were really, a matter of time, given, kind of the growth in the percentage of kind of payments versus fee for service. MedPAC has done a lot of work in that regard. And I think their work is directionally right, even though we don't agree with all of the numbers specifically. So just to really point out that plans are already under some pressure. And I guess pivoting over to the drug list, as you noted, we've got the first 10. We're seeing about 22% net price reductions. That list expands to 15 in 2027. And then in 2028, you'll have Part B, as in boy, the more infused and injectable products, which are for chronic conditions that are going to be in the mix. And what I would say about that is that, Wall Street was not terribly concerned, I would say, with this first 10. I would say that the growth and net reductions were in line with what is the company in their earnings calls mid-August. So now we kind of get to 2027, 2028, when things could get a little more interesting, because now we have a sense of how the agency is calculating prices, maybe not with full transparency, but in their guidance for 2027, I would point out, CMS said, look, we're going to take lessons learned from 2026. We're going to allow for more stakeholder input, patients, stakeholders, maybe provide a wider therapeutic landscape to base these prices. So there is a community of folks that think that the prices could be even lower in 2027. And then in 2028, that's probably a year where investors, broadly speaking, are more nervous, given you have Part B and then the specific dynamics around Part B being reimbursed at ASP +6. There's, I think a concern that those prices are going to be those reductions, are going to be a little bit deeper. So I realized I just mentioned a lot of different things on the health plan side and on the drug side, but one more thing I wanted to mention briefly is that, plans are required to include these negotiated drug prices on their formularies, but they don't really say at which tier. Think about if a product has a therapeutic equivalent, is that company potentially rebating and then has more favorable coverage? So I think there's some concern around where formularies and things may fall out, even with this first list of 10, will they be, prescribed first, given rebate dynamics that are still in play for the competitor medicines?
No, great points. And as Joel mentioned, I guess we'll find more about what those formularies and the prior auth and everything will look like just in a few weeks, at least for this first initial list. Ken, welcome back. The question I had posed to you was, there seems to be a lot of focus around drug prices as a cost driver, particularly for Medicare, but in general as well. And the question was, what really is driving that focus? And is that the cost driver we should be focusing on if we want to manage costs in Medicare and get a handle on healthcare spending?
Well, thanks for the question. And this is what happens when you have an electrician over here working on trying to replace some lights. So they took me out rather than fixing the light. To your question, the real drivers of the change in growth in healthcare spending are the growth in hospital and physician services. They account for over half of the growth in healthcare expenditures. Drugs are anywhere from 12 to 15, 16% of the increase. I think the focus happens because of the design of benefits. If you look at what patients pay out of pocket for hospital care or for physician services, it's much less than patients pay for prescription drugs. So it's more front and center in their mind. So part of it's benefit design. I think just following on what Mark was talking about, and Joel as well, it is unfortunate. The good and bad news of this is that the good news is I think the best part of the act is the $2,000 out-of-pocket cap. The flip side is that it's going to put pressure on premiums. What I'd like to do, though, is broaden the discussion on this a little bit, because if you think about it, Medicare has two really independently separate programs. You've got Medicare Advantage and you've got traditional fee-for-service Medicare. And one of the things that I find sort of exciting that CMS has allowed the MA plans to do is for 8 major categories of, really critical chronic conditions like CHF, COPD, heart disease, rheumatoid arthritis, depression, mood disorders, diabetes, hypertension, previous strokes, that they've allowed the plans to eliminate or reduce cost sharing. So patients that are enrolled in those plans that are participating in that face across the board lower cost sharing for these critical chronic conditions. And what we're finding is not only in the research literature, but we're finding in reality, if you look at total per capita spending, not just thinking in a silo around drugs, but if you look at total per capita spending, by reducing those copays, it either is budget neutral, or many of the plans are finding it saves money. The research literature shows basically that for patients with 4 or 5 chronic conditions, if you reduce what they pay out of pocket, total spending, and this is among seniors, goes down by about $1.80. So we don't think about these interactions. We're so focused on silo-based healthcare policy that we don't think about the broader opportunities we have to reduce hospitalizations, reduce clinic visits, reduce ER visits, by keeping patients healthier, avoiding that heart attack, avoiding that blood sugar spike that Dr. Fendrick knows so well. We have it in one part of the program, but we have it in a very limited sense in the traditional fee-for-service part of the program. So, the focus was on the insulin piece, which is fantastic, and in the $2,000 out-of-pocket cap. I think the experience that we've seen in reality with a broader use of zero or low copays for these really important chronic conditions not only improves health, it improves medication adherence in particular, but it has the opportunity to reduce overall spending. And those interactions between medication use and total spending really have not been brought up, unfortunately, in the thinking and debate about health policy reform. And I think as we move forward, it really needs to be. So I think too much focus on drug prices. It's not the driver of the growth in healthcare spending. It really is in the hospital and physician and clinic services sector. But I think politically it focuses there because there's been some documented high priced drugs. As we talked about, most of those are really not part of the initial negotiations because they're not focusing really necessarily on high priced drugs. They're focusing on where Medicare spends most of its money. And a lot of those medications really aren't that expensive. So it's an interesting policy approach to a problem, that is much broader than just coming in and capping prices. Maybe we'll turn back around to sort of the role of PBMs and others in the debate going forward. But anyways, I think there's an opportunity to really highlight some of the opportunities that we've seen in MA for the broader Medicare population and really think more broadly about the interactions between medication adherence, increased use of appropriate and important medications, and what impact it has on total spending.
Great, thank you. Mark, I want to bring you in on this as well. You wrote an excellent piece recently that it was in Health Affairs Forefront about just those types of issues. What are some of the opportunities for policymakers to make a bigger impact on out-of-pocket costs for beneficiaries? So can you tell us more about that, where you see those opportunities and how the IRA, could address them or does or doesn't address them?
So fortunately, like last night's debate, you had my mic muted during Ken's comments because you'd be hearing me giving him a standing ovation. Dr. Thorpe, we've been working on these issues for a long time, and for you to call out the CMMI MAV bid demonstration and not me is fabulous. We worked very, very hard to make this happen, watch it evolve. And Ken, the Michigan fan, I'll send him a maize and blue foam finger that says we have to change the healthcare conversation from how much we spend to how well we spend. And this is exactly what people at the Partnership to Fight Chronic Disease have been working on. The best way to reduce expenditures is death. Woody Allen said that in the 70s. It's the same today. There's more than enough money in the system, Candace. If we just spent more on the good stuff and less of the bad stuff, we certainly would be healthier. We haven't talked much about the disparities that Ken and I have studied in healthcare delivery for decades in our work to enhance equity. And it shouldn't surprise people that cost sharing is disparity worsening. And those programs, like he mentioned, what we've done in other areas to reduce cost sharing for essential services is actually equity enhancing. So I'll leave how to deal with the premium increases to you, Joel. But what matters to me is that patients get the care that I know will help them better. So, so how much to how well is really, really important. And I just want to call back. It's hard to believe it's 5 years ago. Joel knows this IRS regulation very well, 2019-45. The numbers don't matter, but this was an element we worked on for a decade to allow health savings account qualified high deductible health plans to designate many of the services that Ken mentioned to allow those HSA plans to cover those medications and services on a pre-deductible basis. It should come as no surprise, as my mother said, that you have to spend millions in grant funding to show that if you make people pay less for something, they buy more of it. And Paul Fronston at EBRI has shown that my mother was right, that in those HSA plans who have removed the deductible requirement on those services for the diseases that are very much the focus on PFCD, people are actually doing better. Are some spending less money in aggregate? Yes. Are others spending money in more in aggregate? Also true. But the idea of holding healthcare to cost neutrality is something I've pushed back on for decades. Education should not be cost neutral. Transportation and defense should not be cost neutral. And certainly healthcare is worth paying for, in my opinion. But I think the idea of moving value-based insurance design forward is, of course, to expand the number of services that could be covered on a pre-deductible basis. David Ricks, the CEO of Lilly, and I wrote a piece in Fortune that if we could lower out-of-pocket costs for insulin, which is what we wrote on, why can't we do it for mental health and HIV and the other conditions I see Ken nodding that we have fought so hard, for which there is no moral hazard, there is no overuse, and a group called No Patients Left Behind have done some really fabulous videos kind of reiterating the Horton Hears a Who message from here in Ann Arbor that Americans should not have to have a bake sale, an online fundraiser, go into medical debt or bankruptcy because they are trying to access something that may meaningfully change the quality and length of their life. So I'm looking at you, Joel, because I know you're not an actuary, but you're on my screen. So how the heck are we going to pay for these things that, particularly in the short term, even though Ken is right that there are offsets that down the road in hospitalizations and ED visits, but you have to buy more things now. You could raise premiums, which is what we heard Ipsita and Joel talk about. I don't like that. You could raise cost sharing, primarily deductibles, which I like even worse, which Joel and Ken know has been kind of the focus of my work since the Medicare Modernization Act created HSA plans. I love triple tax advantage savings accounts. I don't like the fact that my patients have to pay full price in January for things like insulin that may and commercial plans that may need to keep them alive. So how do we do this? I mentioned this briefly, but what we need to do is have the courage to hold clinicians accountable for ordering services that their own professional societies say they should not do. And where we start, and this is where I look to people who have policy interests, is that while in the ACA, we use the important word shall cover U.S. Preventive Services Task Force A and B services 100%. That same organization, the U.S. Preventive Services Task Force, gives some services a D rating, meaning do not do. The harms outweigh the benefits. Our colleagues at UCLA and here published a paper a few years ago showing that Medicare pays close to $1 billion on the 7 most common D-rated services. If you cover the cascades of care that come, say, with an abnormal prostate cancer screen in a man over 70, that multiplies every dollar by 6. So when I tell people like Joel that's several $1 billion a year, they listen to me. And we could buy, Ken Thorpe and I can buy a lot of high value, some low cost, but some high price services that patients aren't getting now in the Medicare program due to benefit design issues, as well as what Joel mentioned earlier, which is not new, barriers to effective services through things like prior authorization, step therapy, and one of my nemesis, non-medical switching. And then isn't it horrible, Joel, when my colleagues actually do all that work to finally get approval from a health plan for a patient to get these services, they realize they are hashtag insured but not covered, in the fact that they get insurance approval and they can't afford the out-of-pocket cost to actually get the darn thing that I spent hours getting approval for. So both you and Ken and Ipsita as well, the idea that we have to think simultaneously about the provider side as well as the patient side through benefit design, which is the focus of our work. So the more we could push thinking to clinically nuanced benefit design, and there's lots of various things out there, Candace, that are being floated around in individual employers and plans and at the federal level, because it's very attractive to be able to tell a patient that you don't need to pay out of pocket, say for a follow-up colonoscopy after a stool test, which is a very small but important piece of federal regulation that we worked on decades to implement.
Great examples. Absolutely. I do want to go back for a minute and talk about some of the timelines. We talked a little bit about and looking toward the future. Ipsita, I wanted to talk to you a little bit about what you're hearing. You said the market kind of, was like, okay, the first list of 10 was in line with what was expected. As you know, the IRA also sets up a different, a different timeline for different types of medicines in terms of when they are will enter negotiation for Medicare pricing. Small molecules, medicines, so the pills, the patches, the syrups that are really important for people with chronic diseases, addresses health disparities in terms of access, are subject to a shorter time frame. Are there areas like that or therapeutic areas? You talk about Medicare Part B coming into play down the road. Are there key areas that you see where there may be more concerns that could be adversely or positively affected by this difference in timeline or the different aspects of the IRA in terms of risks and benefits down the road for innovation?
Sure. So I realized also you had asked Candace earlier about this idea of expanding the numbers, like we're at 10, 15, 15 for 26, 27, 28. And I would just mention on that, like really, once you get past 28, you're getting between now and 2028, I should say, you get the bulk of the savings. So they could make it 70, they could make it 100, but it doesn't really matter. It's really these first few years that matter as far as savings to the system. And then, yes, to your point, there, of course, is this 9 years and 13 years, small molecule, large molecule. There's some bills in the Congress, by the way, to address that, the pill penalty bill. There's also a Orphan Cures Act that would address the orphan issue, which, quite honestly should happen. I don't know that these will happen anytime soon, just given that there's a price tag associated with them. But perhaps under the right sort of congressional and White House kind of composition, you could see one or both of those move. So I just wanted to mention that sort of is in the mix. And again, we think the orphan fix ought to happen, probably won't happen anytime soon. And then the bigger issue of innovation, absolutely. With small molecules, you have mental health drugs, you have oncology medicines, only one cancer medicine, maybe two on this initial list, but you're going to see more of that in the subsequent lists. So again, we're just a little bit more concerned about 2027, 2028. Ozempic will come in, semaglutide is likely for negotiation in 2027. And so early on, I will also kind of looking in the rearview mirror after the Inflation Reduction Act passed, company CEOs were very vocal about hey, you know what? We're going to, it was at ASCO, which is the big cancer meeting in May out in Chicago. One of the company's CEOs said, look, we were going to move this medicine through in ovarian cancer. Well, guess what? We're going to move this over to prostate cancer because that's a bigger indication. And the juice may not be worth the squeeze given what we're now seeing is a part of the Inflation Reduction Act. So again, companies were very vocal about clinical programs that they might just pull all together. And I think there certainly is that issue even now, VCs and other early kind of biotechs feeling like they may not pursue certain therapies, particularly in a Medicare population. And they might say, you know what, we'll fund this epilepsy pediatric medicine, but not necessarily for the elderly population given IRA. So I think I'm kind of mentioning a few different puts and takes, but I just wanted to get at some of those issues that we're thinking about.
Yeah, no, absolutely. Thank you. Joel, Ipsita mentioned a few bipartisan areas of interest, orphan drugs, small molecule medicines, and others, I'm sure, in terms of IRA reforms. What's the appetite like now and kind of heading into 2025? What do you think in terms of what we might see?
Well, I think what's happening in the Part D plan market hopefully will inform Congress and the administration that this is not a perfect law, that changes are necessary in order to protect primarily beneficiaries from increasing out-of-pocket costs, increasing premiums, less plan choices, more friction with plans in terms of formulary management, formulary exclusions, and that the issues that Ipsita just raised are legitimate issues, right? Like we never get the law perfect. There needs to be adjustments. And so the timing issue is critical because it's driving incentives into biologics. And I think there was this sense that, somehow biologics are the future on the part of the congressional authors, but really in terms of access, particularly in low income areas, disparate access areas, minority populations, we want more pills because the pharmacy is in the area, the doctor may not be. The other thing is that that's a lower cost point of intervention for a patient to go to a pharmacy versus maybe a physician office or a hospital outpatient department or an infusion center. So this incentive to go to higher cost, higher sites of care inherent to the IRA, I think will be a big issue next year. And then the Orphan Act, Orphans Cures Act, Ipsita mentioned, another thing high on the list. These are both bipartisan efforts. And so we're hopeful that those get changed. But I think it's a mistake to say that the negotiated prices, Wall Street kind of shrugged and said, not a big deal. This is kind of what we expected, pretty close to the negotiated net plan price. This is, first of all, going to impact Part B, as in boy, providers within the next couple of years. It directly affects their reimbursement because they get paid off the drug. And what we'll see is more community access shut down as oncologists and other providers sell out to hospitals, and we'll see even less access in those areas where we need more access. But the second thing is the reason for that is that it's a change in approach, right? Like the original law envisioned hiring private experts to negotiate these lower prices. That process was benchmarked by some guarantees to patients that they could get access to drugs, they have an appeals process. Now we've got a political process. We've got bureaucrats and politicians making a decision around what the price is based on whatever they want, right? They're supposed to take factors into consideration, but I can take into consideration whether to take an umbrella outside today because the weather service says it may rain. Doesn't mean I'll take the umbrella with me. So the politicians and the bureaucrats are now in charge. They're acting kind of like a PBM. They saved $6 billion. They're passing 1.5 on to beneficiaries. Why aren't we negotiating on behalf of beneficiaries first, taxpayers second? So I think some of the approach changes is what we'll see, particularly if there's a Republican sweep, that they would look at like, who are we actually negotiating for? How are we setting these prices? Do we want a political process engaged, or do we want to maybe have the private sector more advantaged here? And then the benefit redesign benefiting the patient first. I would say the last kind of change with that respect, in respect to that is, if we're going to negotiate or set these prices for these drugs, we ought to ensure the plan cover these things at the lowest tier of the formulary, or maybe not use aggressive utilization management on these products because the taxpayers were involved in negotiating this lower price. So there's multiple changes that need to happen to this law. There's no perfect law. And I think what we're seeing on the premium side of things, the choice side, the access, is all conditioning the environment for next year to try and make some of these changes.
Thank you. So looking into next Congress, not necessarily a lame duck. Okay.
Yeah.
We'll hold you to that in your crystal ball. I did want to we did get a couple audience questions that I wanted to share. And Ken, I'm going to put this one to you. A number of you have talked about how the IRA increases liability and costs for Part D plans and Medicare Advantage drug plans. And what I've heard from you, and correct me if I'm wrong though, is that you anticipate that will mean more utilization management, step therapy, and narrower formularies as they manage those risks. They're taking on the added costs, and so they'll be ramping up, more utilization management. CMS has taken the view that they're going to wait and watch to see if this happens and before taking any kind of steps to intervene. Ken, do you think that's a wise approach, or should CMS go ahead and step in and start offering some guidance about expectations on utilization management for medicines, particularly those that are subject to negotiation?
Well, yeah, I think it would make some sense. I mean, on the one hand, what's being heavily sold is that this is a big benefit to patients in terms of reducing cost to them of getting drugs that they're currently taking. On the other hand, if you have sort of a set of ancillary moves by plans that are restricting access to the drugs you're currently taking, then clearly the reduction which you pay out of pocket is not quite as important. Again, I think it goes back to my main point that I was talking about, is that really until we start thinking systematically about healthcare costs and how Medicare and private insurance can reduce the growth and level of per capita spending, clearly medication and medication adherence is central to this. This is where all the money is in terms of chronic disease. So rather than treating it as sort of the enemy and a cost center, it really, I think, to Dr. Fendrick's point and all the work that he's done, focusing on the high-valued medications that are going to keep patients healthier, and reduce overall spending should be the focus. So I worry about myopia here. I worry about short-termism, where we look at simply the cost of a treatment in year one, but we don't think of the downstream benefits of it. And certainly, as we've seen from the hepatitis C medications, that's a great example of yes, it was expensive initially to get it out there, but we know the benefit of it in terms of reduction in hepatitis C. We also know the benefit of it in terms of basically eliminating retransmission of it. So I would almost give it away free if I was running a prison system, because it's effective. And again, the focus on a silo of spending drug costs is really missing the main point. And I think to Mark's work on this and the excellent work that he's done on VBID, that is the point, is that if we're going to regulate healthcare spending by silos, that doesn't make a lot of sense, because it doesn't understand the impact it has on the patient overall.
I think Mark wants to get in on that. Mark, I see your hands raised.
I want to hang around with Ken as often as I can. So just like Joel and Ipsita don't want me making policy, Joel, I love what you say about politicians and bureaucrats. You know, Ken and I have argued for decades that, keep the government out of our office. I think as we wind down here, I just want to build on what Ken said. 35 years in practice for me, it's really important to say a few things. One, there's never, ever been a better time to be a clinician. I mean, it's just truly remarkable. Ken mentioned hepatitis C. The reason I didn't become a pediatrician was watching the horrible complications of sickle cell disease among young kids in Philadelphia, where I trained. The thought that we could potentially have a cure for this condition among many of the other gene therapies, cell therapies, CAR T, it's just mind-boggling. So we can't forget why we're in this business, of course, to improve individual and population health. My focus, of course, is on underserved and disproportionately disparity communities. And so many of these policies are directly impacting these important metrics. When it comes specifically to the idea of drug price negotiation, the IRA, I grew up having to give bile sequestrants before statins and H2 blockers before the best GERD medicines and antidepressants. And, the idea of barriers to the best care has always been in front of me. But the fact that we're actually saying now that it's because of money is refreshing, but very concerning, and which is why we need the Ipsitas and the Joels around to hold people to bear. So $5 trillion. Reporters like the ones on this call asked me, is that too much or too little? And the answer is, until you tell me what we're buying, I'm not going to answer the question. There's more than enough money in the system. And what a value-based insurance design and so many of the colleagues, including those at Partnership to Fight Chronic Disease, is let's just move the money around. We spend money on the wrong services to the wrong people in the wrong places in the wrong time. Joel, I'm summarizing your 4 minutes in a quick soundbite. And if we could put policies in place that are often imperfect, that could at least move the needle toward more of the good stuff and less of the bad stuff. So much so, but well, when it comes to specific about the IRA drug price negotiation, if you and your clinician agree that that drug is right for you, you are likely to benefit. Ipsita mentioned there are some shenanigans that may occur that may not be the case, but I'm somewhat confident that if you take one of those 10 drugs, 15 next year and so on, you will benefit. But I want to remind the non-policymakers that in the course of these chronic diseases, many of these patients require more than one drug to treat that condition, and they're on several more drugs to treat other conditions. Then we often have to switch drugs because of complications, because of drug-drug interactions, because of allergies. So the thought of the idea that I'll have one anticoagulant or one oral hypoglycemic or one mental health drug or one drug to treat a common cancer just doesn't jive with the precision medicine that we're so excited about as clinicians. So I'll leave you, Candace, you have others, precision medicine needs precision payment and precision benefit design. I'd much rather not know I had a therapy that may help my patient than to know that it's there, but I can't get it to her.
Right. No, absolutely. And we're pushing up against time, but I did want to get one more question in, but you're absolutely right. And I feel like maybe if this group could get in a room, we could solve a lot of this. Joel and Ipsita, I think this one might be more directed to one or both of you. And the question was, is there really any way to tell how much of an impact drug price negotiations will have on premiums going forward and plan availability? You both have kind of touched on that, but maybe Joel, if you could take premiums, and then Ipsita, if you could take the plan availability. And we've got like a minute, so 30-second lightning round.
Yeah, I think the theory was we negotiate lower drug prices, set lower drug prices, and that lower cost would then translate into offsetting reductions in premiums. The premiums would be less as a result. I think that theory has yet to play out. We're not seeing it in the market, and that's a shame because we need a more generous benefit. We just we can't make it so expensive that people can't access it. And I guess to build off what Ken and Mark said, ultimately I'd like to see increases in drug spending and decreases in hospital spending because those drugs can prevent acute episodic hospitalizations, which no one wants. I think the goal at the end of the day is let's get great insurance coverage at an affordable price that encourages people to stay healthy and out of the hospital. And we're going to have to spend more on drugs. We have to spend probably more on physician services, but we should be spending dramatically less on hospitalizations.
Ipsita, in terms of plan availability, is there a way to tell how the IRA is going to impact that?
Well, already plans are exiting counties and reducing their footprint in Medicare Advantage for 2025 and beyond. A lot of that was due to new risk adjustment programs and, some consecutive years of payment reductions from CMS, which, some would say might have been necessary, supplemental benefits, a whole lot of changes to the Medicare Advantage program. Insurers have a much higher liability with Part D restructuring in the catastrophic phase. And the initial phase, you have a $2,000 out-of-pocket cap, which is great for patients, but it could make insurance more expensive. So I feel like we're early innings, but we already know Part D premiums rose last year and will this year. We've got this CMS demo that kind of proves that point. So I'm a little concerned about that, but I guess time will tell.
Thank you. Now, thank you all for the great discussion today. And thank you to the audience for the joining us and for the questions in advance. We did record today's webinar and we will post it along with the other recordings of our previous segments of At What Cost series. It is on the Partnership to Fight Chronic Diseases YouTube channel. And we'll continue to explore these issues and welcome you to interact with us as we do that. Encouraging you to follow along at the hashtag, using the hashtag #MoreThanAList, and obviously on our website, which is fightchronicdisease.org. Thank you again to the panelists. Always great to hear from you and appreciate you taking the time to share some great ideas today and ways forward.